Good morning, dear audience. Now I shall try to summarize the state of chemotherapy in cancer disease. Before going into the treatment, I should stress that if we cannot prevent cancer, we should at least try to diagnose the disease earliest possible. Because if you diagnose cancer in the first or second stages, the chances of cure are very high. Cancer in this early group can be cured from 85 to 95% of cases. Now, when we speak of cancer chemotherapy, we have to start with the history of chemotherapeutic agents. These cancer drugs start with Goodman and Gilman, two American investigators who started the first cancer drug from nitrogen mustard gas. This was a gas used as a poison in the Second World War, and afterwards it was seen that this nitrogen mustard was active against lymphocytes, against lymph nodes. So in 1946, nitrogen mustard was proposed as a cancer drug. In 1947, 1 year later, Sidney Farber, a chemist at the Harvard School, created methotrexate. In 1951, 6-mercaptopurine was discovered. In 1957, two investigators at the National Cancer Institute in America, Fry and Freireich, started to treat childhood leukemia with methotrexate and 6-mercaptopurine combination, and they found that there was a 45% cure rate. Then in 1960, both researchers combined 4 drugs under the name of VAMP: vincristine, methotrexate, mercaptopurine, and prednisone. With VAMP, the leukemia results were around 80%. Again, in 1966, 6 years later, Vincent DeVita at the National Cancer Institute proposed MOP treatment in Hodgkin. MOP was mustargen, oncovin, procarbazine, and prednisone. And he found 60% cure in Hodgkin disease, which was a great finding at that time. Rubicin or adriamycin was discovered. It was at that time a great discovery, and Dr. Rubicin has entered many protocols, many regimens in chemotherapy. In the 80s, the platinum compounds were discovered, and in the 90s, the taxanes like paclitaxel and docetaxel were discovered, and at about the same time, an investigator called Einhorn has proposed a protocol of 3 drugs, bleomycin, Velbe, and cisplatin, in testis tumors with a cure rate of 85%. After that time, many schools, many investigators have proposed hundreds of combination regimens in solid tumors. You can find them in many books of chemotherapy, but usually in the 3rd and 4th stages, The results are not brilliant. They are giving about 3 or 4 months response rates, and although they don't influence very much the survival, maybe they are adding to the comfort of life. Late 90s and early 2000s, targeted therapy was introduced. The targeted therapy drugs were in part small molecules and in part monoclonal antibodies. These drugs were attacking given points in the cell, in the DNA or in the metabolic enzymes. This is why they had been called targeted therapy. Targeted therapy drugs are rather new, and their results are not fixed as yet. We don't have very sure statistics about their action. And when you look altogether, the results of chemotherapy in patients with first and second stages is rather satisfactory, but in third and fourth stages the results are not so satisfactory, and in our next talk we shall try to see what can be added to this standard chemotherapy to increase the response rate and the survival period of patients. Thank you for your attention.